On this edition of Next Africa, we take a look at how the Trump administration's overhaul of U.S. foreign aid is facing a major test as a growing Ebola outbreak spreads through the Democratic Republic of Congo and Uganda. And as cases rise, Africa CDC Chief Jean Kaseya warns that containing the virus will require more funding, not tighter border controls. Plus, with no approved vaccine for the rare Bundibugyo strain, efforts to develop one are accelerating. We'll speak with Mark Feinberg of IAVI, who says clinical trials could begin only by the end of this year. Welcome to Next Africa. I'm Jennifer Zabasajja. The Trump administration's overhaul of U.S. foreign aid is facing a major test in Africa as a growing Ebola outbreak spreads through eastern Congo. For decades, the U.S. was at the center of global outbreak response and preparedness through agencies like USAID and the CDC. But after the dismantling of USAID and withdrawing from the World Health Organization, America's role looks very different. The administration has been rolling out an America First health strategy, replacing traditional aid programs with country-by-country agreements that require governments to contribute more of their own funding and take greater ownership of their health systems. Supporters say the approach promotes self-reliance and reduces dependence on foreign aid. However, critics warn that countries struggling with debt, regional conflicts, and already weakened healthcare infrastructure may be forced to absorb funding cuts too quickly. I caught up with Janice Q, Bloomberg Africa healthcare reporter, on some of the challenges facing the continent.
We already saw a lot of funding disappear last year. So there was obviously the USAID cuts, but there were also cuts across Europe and a lot of major philanthropies. And that came at the time that African countries are still facing incredible fiscal challenges, very, very high debts. There are more than 30 countries that spend more on servicing debt than they do on health. Yeah. And so the risk really is that scaling back has happened before a new system was put in place that could replace it. And that leaves a lot of populations incredibly vulnerable. And we are seeing some of the effects of that now playing out again in this latest outbreak of Ebola in Congo. And we are seeing the risks amplified because of these changes that have happened quite abruptly.
Some of the messaging too around this latest crisis, as it pertains to the agencies that are running the response to it, has been very interesting as well, because we've heard from Africa CDC as it pertains to the amount of funding that they need and that they've actually received, which made me think, what are the dynamics between the World Health Organization and the Africa CDC? Africa CDC is a bit newer. How are they interacting right now? Where are things working, and maybe where is there more room for improvement?
We really saw Africa CDC come into its own during the COVID problems, and they have taken quite a strong leadership role on the continent. So they're effectively an organ of the African Union. And they've got a lot of interaction with the specific individual countries. But as you say, the WHO is older, and it has a global reach. So when outbreaks have been declared public emergencies, like this Ebola outbreak, WHO can declare a global emergency, whereas Africa CDC's emergency it's a newer one, and it is continentally focused. Really, the main thing with calling these effects of as we call them, is to marshal resources. And at this point, marshalling resources in any which way is really useful. I do think that there is an element where the two are working closer together than ever, partly because both of them have experienced some defunding. And so they've got fewer resources, and to pull resources together makes a lot more sense. It also is very important in terms of having a coordinated response.
What does this mean then, outside of the outbreak, for response and preparedness moving forward on the continent?
There has been a huge drive from the Africa CDC specifically to make sure that we get manufacturing of vaccines and medications on the continent. And that is still a big focus, but as we've mentioned, with the funding cuts, it becomes more challenging. We import, in Africa, we import over 90% of what we use in terms of vaccines, and it's something close to that in terms of medications and drugs. Testing kits, all of these are incredibly important tools that, prevent spread, etc. And so to be prepared, it's not a luxury in Africa, it's a necessity. We know that there are going to be further outbreaks of various things, and that preparation is vital, but it does take time and it does take resources and funding.
As governments focus on keeping Ebola out, the Africa CDC says the real priority should be containing the outbreak at its source. Director General Jean Kaseya told Bloomberg's Africa managing editor, Arjit Ghosh, that more funding is needed to stop the virus from spreading, and warned closing borders alone is not a solution.
Western countries, all of them are cutting funding to Africa. And some of these programs were supported by funding coming from Western countries, like for human resources, for testing, for transportation of samples. And suddenly, African countries have to think how to fund money and to cover this gap. But it takes some time. And I think the combination of all of these factors are fueling this mistrust that we see at community level.
I wanted to talk about this focus the U.S. has, of keeping the Ebola out of its own country. Now, does that stance present an hindrance to fighting the current Ebola crisis, you think?
We value the support we got and we are still getting from the U.S. And we think that if we continue to work together, and there is no reason for the U.S. not to work with Africa CDC, now as everyone knows that Africa CDC is the leader in terms of public health in Africa. There is no reason for us not to continue to work strongly because we have strong relationship in the past.
When will the trials of the antivirals and antibody-based treatments actually begin, and where will it start?
We are assessing all candidate vaccine. We are working together with CEPI, with WHO, with all other partners. And we also have some other people. I have a pharma company in Egypt. They say they can also offer solutions for vaccine. We are opening our mind. We say we are waiting. We are assessing all candidate vaccine. I cannot tell you exactly what will be our first priority because we need to see, based on all candidate vaccine, there are 3, 4 now, and where we can start. For sure, DRC, they said they are ready for clinical trial. There is no problem to start in DRC, but let us finalize this conversation that we have, and then we can launch that.
Africa's CDC has said that the fight against the current Ebola crisis, you'd probably need some $500 million, but you've only raised little less than half. What is the reason that the funding isn't coming to you, considering that it's such an important and crucial fight?
The solution is not to close borders. The solution is to provide sufficient support to contain this outbreak where it is. Then, if Western countries, they know that, African countries, they are doing their best. They are also providing, and this meeting on the 16th of June, we'll see many African countries coming to pledge funds. But it will be not sufficient. And we are saying to Western countries, it's still the momentum to contain that. Please come work with us. We need $518 million. With that, we can ensure you that we can contain this outbreak. It won't reach you. But if you say we don't provide funding, we close our borders, I can assure you that this one will not be a solution. And one day, all of us will be surprised to see that this Ebola is somewhere else.
Vaccine developers and funders are pushing forward with 3 experimental shots against the Ebola strain spreading in Central Africa. The Coalition for Epidemic Preparedness Innovations is committing more than $60 million to fund 3 vaccine candidates, which are being developed by IAVI, Moderna, and the University of Oxford. However, the key challenge is to bring the vaccines to patients in clinical trials as soon as possible, with the CEO of IAVI suggesting its shot could start trials by the end of this year.
We're not starting from scratch. There's a lot of experience in making vaccines successfully against Ebola viruses, but we need to start from the relatively early stages right now to expedite the development and availability of vaccines to address this current outbreak. The number of different approaches are being explored by different investigators. They're all based on platforms for vaccine development, which have been successfully utilized previously, and trying different platforms is important so that we can maximize our probability of success.
Can you say how far out you think a vaccine for the Bundibugyo strain is?
Well, the vaccine that we're developing, we hope to have into clinical trials by the end of this year. But those trials will take time to conduct. The other programs could potentially get to the clinic a bit earlier than ours, but it depends on what additional preclinical data they need to generate. But I think all of them will probably end up approximately in the same place at around the same time. So we would hope that clinical trials would be well underway with the different candidates by the end of this year. If for some of the other candidates, it might even be a bit sooner than that.
And are those trials happening on the continent? We talk quite a lot about how a lot of the vaccines that end up getting to the continent are not produced or manufactured on the actual African continent. Is that the same case for what we're seeing right now with the current program that IAVI is working on?
Well, IAVI's been working in Africa for approximately 25 years, and a significant number of our staff are African and based in Africa. So for us, it is a normal course of our operations to do our studies in Africa if they're targeting diseases that impact African populations. And we also have a long-term commitment for those vaccines to be manufactured on the African continent. We established a partnership with the Institute Pasteur in Dakar, Senegal, for the manufacturing of our vaccines. That will take probably a few years to actually fully implement that partnership where the vaccines can be manufactured there. So we will be manufacturing them outside of the continent, at least initially, but intend fully to transfer them so they can be manufactured on the African continent. But for us, we believe it's critically important to do the clinical studies on the African continent and really have that be visible and understood by the communities there, and have it be done in partnership with African investigators and African communities.
The Ebola outbreak is also prompting a broader effort to mobilize funding. The AFDB president tells me the lender is working with health agencies and governments to assess what support is needed. Take a listen.
AFDB team is working currently with Africa CDC and WHO and also the concerned countries to assess what is the level of support which is needed from the bank in coordination with other donors, because we should not duplicate the effort of all the partners, but rather to focus on 2 types of intervention. One is the short-term intervention to support the country to face the current situation, and the second is to support the health system in the concerned countries.
Coming up, we examine the impact of Trump's post-USAID health strategy in Mozambique, where the transition is raising questions about the future of healthcare across Africa. Welcome back to Next Africa. I'm Jennifer Zabasajja in Johannesburg. The Trump administration's decision to dismantle USAID is reshaping healthcare across Africa. Mozambique has become a key test case as countries adjust to a new U.S. aid model that provides less funding and requires governments to take on more of the burden.
The United States Agency for International Development, or USAID, was the main way that the American government deployed health funding across the globe. They were really a major health funder in many countries, particularly in Africa. They've covered a lot of very serious diseases like HIV, malaria, tuberculosis, providing aid both in terms of collecting data, actual medicines, and staff. For Africa, this has been vital. In January 2025, President Donald Trump made a series of rapid decisions that effectively dismantled USAID and froze most U.S. foreign aid. The current US-Mozambique deal is a 5-year bilateral health agreement. It was signed in late 2025 under Washington's America First Global Health Strategy. There is a risk of a gap. If the Mozambique government cannot adapt quickly enough, that could mean disruptions in what they can provide for HIV and malaria and tuberculosis. The new US deal gives Mozambique a funding window and a broad direction. There's more country ownership, more domestic financing, less reliance on outside implementers. But the practical roadmap, how to replace lost capacity and raise health spending in what is really a fiscally distressed country, to rebuild surveillance and sustain HIV and malaria programs, that's still pretty uncertain. Europe and China may play a role at the margins, but neither is positioned to step in at scale or in the same way as past US support. Many African countries are really working from a position of constraint rather than choice. And so they've got to accept them in many cases because the funding is still substantial, but they are doing it under duress. African countries are responding in a few different ways, and they're not always aligned, pushing back or slowly negotiating over the concerns that they have. Some of the concerns include sovereignty and data sharing. We've seen Zimbabwe reject the deal that they were offered outright, and Kenya, which was the first to sign, is now facing citizen pushback, with that even going to the courts. Mozambique is really part of a global web when it comes to health coverage. Diseases don't care about borders. We definitely saw with the COVID pandemic, infectious diseases can move quite rapidly. So if there's going to be widening gaps in coverage, there could be a big problem. Whether there is going to be short staffing or stockouts of various medications, these things are real life, impactful situations where lives are at risk.
As more nations weigh the trade-off between funding and greater responsibility for their own health systems, attention is turning to how these agreements will actually work in practice. Danielle Nirandutia, senior fellow at the Center for American Progress, says the devil is in the details.
This outbreak exposes is the need for countries to have permanent intergovernmental structures that are empowered, that have the mandate and the authority and the flexibility to deploy resources strategically and where they're needed most. Currently, what you have, and it's a good, we have the building block, and I think that's the role that USAID has done, building those foundations across the board. USAID was there helping build out the One Health platforms that we talk about, where you bring different sectors together.
On these U.S. bilateral health deals, we've seen a number of countries actually decline some of the agreements. What would you say is the chief concern among some of these countries about these agreements?
There are elements that need to still be negotiated. I think it's a good first step because countries had been asking to be in the driver's seat of their own health programs, and that's fantastic. It was a direction of travel that we were on anyways. So this only further continues it. But I think what we need to be careful about is to figure out how are these bilateral agreements going to be operationalized. The devil is in the details. Who is going to be doing what, where, and how? Where are we going to see the mutual accountability? I think those are the questions that we need to be to be asking of these bilateral health agreements. I think they mean well, but I think it's really for us to kind of look at how are they building on what was already there, the foundation, and then how are countries in the partner being the U.S. Holding each other accountable.
And up next, we take a look at why some African countries are pushing back against Washington's new health aid agreements and what that could mean for healthcare funding across the continent. Welcome back to Next Africa. I'm Jennifer Zabasajja. More than 24 countries across the African continent have signed America First health agreements, with only a handful that have resisted so far. Zimbabwe and Ghana have rejected proposed deals, while negotiations with Zambia have stalled. Kenya, which was one of the first countries to sign an agreement, is now facing legal challenges over the arrangement. Meanwhile, South Africa has not been offered a health agreement under the program so far. For more, we're now joined by Bloomberg Africa correspondent Matthew Hill. Matt, just tell us a bit about some of these African countries where some of the deals have not gone according to plan, and really what some of the key sticking points have been.
Yeah, you can really split it into two buckets. The first being countries that have outright rejected a health memorandum of understanding with the US. There you're looking at Ghana, you're looking at Zimbabwe. And then in the other bucket, you've got countries that have perhaps agreed to a deal, but then have faced legal challenges to what they've agreed to. In that bucket, you've got countries like Kenya, which agreed to a deal, as you said, but then faced a legal challenge from a lobby group, which froze the deal. That's since changed. An appeals court this month has now decided to unfreeze the deal, though the main legal challenge is still with the courts. And then you've got a country like Zambia, which is perhaps a bit of both, where the government has been negotiating a deal with the US government. They haven't rejected it outright. But on the other hand, there are groups that have taken this to court even before anything's been agreed to, over data sharing concerns, privacy concerns, etc.
Let's stick on Zambia, Matt. You've covered the country extensively. Of course, critical minerals is very key to that country. I wonder if we think about critical minerals and some of the debates around critical minerals and these health agreements, how much is it becoming a factor for some of the countries that choose to or not to sign these agreements?
That's a crucial point. Zambia is one of the countries that have said they find problems with the proposed memorandum of understanding that the US has put before them because it wants preferential access for US companies to Zambia's critical minerals. Zambia's the second biggest copper producer in Africa. It's got cobalt, it's got other minerals that are crucial for new technologies that the world is adopting. Zimbabwe is another country that said that the US was wanting preferential access to its minerals, and that's part of the reason why it rejected a health memorandum of understanding from the US. But in Zambia's case specifically, it's an interesting one because over the past 5 years, I would say, the Zambian government has gotten a lot closer to the US, whereas under a previous administration, it was pretty much all in on China. And in the past couple of years, we've seen that relationship changing quite a bit too.
And that's Next Africa for this month. But don't forget our weekly podcast with more of what's happening across the continent, available on Apple, Spotify, and wherever you usually get your podcasts. You can also subscribe to our daily Next Africa newsletter, available on the terminal and website for even more reporting from the Bloomberg team. But for now, I'm Jennifer Zabasajja in Johannesburg. We'll see you